Carlos, thank you very much for the invitation. Karpesh, thank you very much for the introduction. It is a great pleasure for me and an honor to be part of this of this series. And let me share tonight a few things about the history, development of the ulnar head prosthesis, coming to the results, how we introduced it, why we introduced it, and where we do see the indications nowadays. So yes, I do have some disclosures. I'm working together with many companies, so my disclosures actually go to different companies, which makes it easier. But especially for the ulnar head prosthesis, obviously, I'm working together with Carlos Martin, who has developed that prosthesis. So if we talk about ulnar head replacement at all, we always talk about the treatment of the completely arthrotically destroyed distal radial ulnar joint. And what we have clinically is we have a painful loss of forearm rotation. And the aim in this situation is to restore form rotation and reduce the pain. Whenever we still have an intact distal radial ulnar joint, different other options to restore the normal anatomy are indicated. So in the past, or still today, our salvage procedures for this problem are resection arthroplasty, being it complete ulnar head resection, cervical procedure where we do the resection of the ulna proximal to the fusion of the distal radial ulnar joint, or hemiresections arthroplasties as they described by Bowers or Kurt Watson. And whatever of these kind of resection arthroplasty we perform, we will restore forearm rotation. But it is not a reconstruction of the normal anatomy. These are salvage procedures. And with these salvage procedures, we might have the problem that we produce a painful multidirectional instability of the forearm because we lose the buttress for the radius when we resect the ulnar head, and we will show you a little bit later. If we have that instability, it may be in the axial direction, it may be in the dorsopalmar direction, or it may be in the transverse direction, especially if we load our forearm, what we call radio-ulnar impingement syndrome. Does it matter? Yes, in some patients it does matter, as for example in this patient with a kind of hemiresection arthroplasty where you can already see on the plain X-ray the dorso-ulnar instability, and this patient can actually produce the instability just by pushing the extensor carpi ulnaris tendon and pushing the ulna up and down. So why do we have that problem? Because we sacrifice the ulnar head, and the ulnar head has some anatomical function. And in the axial direction, it is a bony support for the TFCC and the ulnar-sided wrist joint, and it is the attachment for the ulnar-sided wrist ligaments. In the transverse direction, the ulnar head is a bony support for the radius, and we should never forget, it is the ulnar head and the ulna is the only fixed point in the complete wrist and hand. And the hand and the wrist and the radius rotates around the ulna. If we lose the ulnar head, we lose the support for the ulnocarpal joint as well as for the radius. So the other anatomical function is force transmission. And we have a force transmission in the axial direction again and in the transverse direction. And we know from the old studies from Andy Palmer and from Werner from 84 that in the wrist joint, we have about 80% of the axial force transmission on the radial side and about 20% on the ulnar side, and this is the opposite way around on the elbow joint, where we have 60% of the force transmission going on the ulnar side and only 40% on the radial side. And we have a transverse force transmission if we load our wrist or if we put something on the radius, because then we have the direct force onto the ulnar head. Now, we hardly ever have that situation in a very difficult and heavy situation. And we usually, in the axial direction, don't walk on our hands. So even the axial force transmission, we have rarely in that kind of way. But what we have in day-to-day living is that we have a combination when we lift something up, where we have an axial in the axial direction as well as in the transverse direction, a load on the ulnar head. So if we sacrifice the ulnar head and the continuity of the distal ulnar, we might run into that problem. To stabilize that complex situation between the mobile radius against the ulnar, still allowing us almost 180 degrees of forearm rotation, we have soft tissue. And the soft tissues are sort of aligned around the ulnar head like a cup on the head. So that the top of the head is a TFCC. Then we have the joint capsule, which is lax and does not give much stability. But on the dorsal side, we have the extensor retinaculum, and we have the 6th extensor compartment with the ECU tendon that really give us stability to the distal radioulnar joint. On the palmar side, we have an additional stabilizer by means of the pronator quadratus muscle. And all together, as I say, in a mobile way, fix the radius and the wrist around the ulnar. So loss of the ulnar head or ulnar continuity will definitely destabilize the ulnar sided wrist and forearm. And what happens then is that the ulnar wrist and the radius drop down in a supination deformity as we know it in the rheumatoid patients. The distal end of the ulnar sticks out dorsally, and the radius falls onto the distal end of the ulnar during forearm rotation and loading. And this is what we call painful instability of the distal end of the ulnar, but in reality, it is a painful instability of the forearm. To solve this problem, if it occurs, and it does not occur in all patients where we do these procedures, traditionally we have 3 therapeutic reactions. We have tendon sling procedures to stabilize the ulnar. We can do a radio-ulnar fusion, a one-bow forearm, or we try to stabilize the situation with the ulnar head replacement. And let me run shortly through these 3 different options. To perform a tendon stabilization of the distal ulnar, all tendons have been used and described. Extensor carpi ulnaris, flexor carpi ulnaris, combinations of extensor and flexor carpi ulnaris tendon, always with the aim to stabilize the distal end of the ulnar. But we know from biomechanical studies that none of them will be able to stabilize the system. And the reason for this is that we try to stabilize the ulnar end of the distal ulnar, but this is not the unstable thing. It is the radius and the wrist that are unstable in projection to the ulnar, which is where it belongs to. So if we try to stabilize the ulnar end, we address the symptom, not the problem. And therefore, these procedures cannot be successful. So what is about radio-ulnar fusion? So if we have a massive forearm instability due to loss of the ulnar head or ulnar continuity, a one-bone forearm could be an option. But with this procedure, it is very, very difficult. Just in the beginning, what position do we fuse the forearm in what kind of rotation? Like in this situation, you really need the supination. For day-to-day working on the computer, we need the pronation. And obviously, somebody who has multitasking professions, you need certainly both of it, or at least a little bit. And then the next thing is that we have very, very little studies on one bone forearm. But this study from 2013 in 10 patients shows us that with a mean follow-up of 10 years, that we have a dash of 77. And the biggest problem is that we had 27 revision procedures in 9 of 10 patients, and only 1 patient had no complications. So definitely, this is no treatment as a therapeutical option for the destroyed distal radioulnar joint. And this is something we want to avoid by all means. So when I visited Tim Herbert during my fellowship in 1992, he already had some good results using the original Swanson ulnar head spacer, the silicone spacer. But in a retrospective study, he could find that that spacer only lasted for the stability for about 1 or 2 years, and then usually it fractured and the stability was gone again. But with this experience in mind, his idea was that if we restore the normal anatomy by means of putting a spacer, a most biocompatible spacer into the distal radioulnar joint and restore the buttress for the radius and for the wrist, we might have a chance to restore the stability. And using for stabilization that system, we can use the original soft tissues, because these should usually still be there after a ulnar head resection or hemiresection arthroplasty. So what we do in a way, we try, if we remember that sort of cap on the ulnar head, what we try to do is we try to fill the empty cap with a biocompatible spacer by all means. So that led to the development of the ulnar head prosthesis that finally was finished in 1995. It consists of a zirconium ceramic head in 3 sizes on a titanium stem with titanium coating for osseous integration, so we don't use cement. The stem itself comes in 3 sizes, and it comes in 3 lengths of collar to restore length if we have already had excessive shortening of the distal end of the ulna. The operative procedure aims for an ulnar minus situation of about 1 to 2 millimeters to avoid ulnar impaction on the ulnar side of the wrist after we have restored the distal radioulnar joint. Preoperatively, nowadays, we do that obviously digital on the computer. We measure the size of the stem we need and the length we need and the size of head we need. The operative procedure itself is based on raising an ulnar-based dorsal capsuloretinacular flap. What does that mean? We actually do make an incision right dorsally over the original distal radioulnar joint. We look for the retinaculum extensorum. We longitudinally open up the 5th extensor compartment, retract the extensor digiti minimi tendon, and in the depth of the 5th extensor compartment, we are exactly in the dorsal capsule of the distal radioulnar joint. We open that up and we lift it off the remains of the distal ulna or of the ulnar head ulnarwards and leave it all in one big layer. And in the end, after replacement of the ulnar head, we reattach that ulnar-based flap with osseous sutures on the dorsal rim of the sigmoid notch. This is the exact procedure. So this is skin incision, and then we actually look for the extensor retinaculum. You can already see the opened up fifth extensor compartment, the retracted extensor DDT minimi tendon. This is the flap we create. Nowadays, I do it more longitudinally. And then we lift up that flap with the ECU tendon and the sixth extensor compartment inside. We measure the length of necessary resection as we have scheduled prior to the operation. We perform the osteotomy, and then we peel off the remains of the ulnar head or the ulnar head, and then we have to look for the TFCC. Like in this case over here, the TFCC has been torn, and in some cases, especially with a lot of scarring, we open in from the inwards the sixth extensor compartment. All of this has to be sutured before we actually continue with the operation. So we try to suture the TFCC, make it one bottom of the cap we create, and then we suture the inside of the sixth extensor compartment to avoid direct contact with the ECU tendon with the ulnar head after replacement. And then obviously reaming of the stem of the ulna. This is straightforward endoprosthetic replacement. And then we have a trial prosthesis. And you can see the trial prosthesis in now. This is a sigmoid notch. This is a TFCC over here. This is our ulnar-based capsuloretinaculum flap that is lifted back. And at that stage of the operation, we have to do intraoperatively X-ray control to make sure that we are in an ulnar minus situation, like shown on this fluoroscan on the right side. And then we reattach the dorsal rim of the TFCC or the radio-ulnar ligament, the dorsal radio-ulnar ligament, on the underside of the flap. And we drill 2 or 3 drill holes through the dorsal rim of the sigmoid notch. And then we reattach that ulnar-based capsular retinacular flap to the dorsal rim of the sigmoid notch under the appropriate tension. And usually we've still got enough soft tissues to do a double layer suture, and we leave the EDM tendon subcutaneously, like shown in this example. And this is what it should like after the operation. And especially in the transfer, in the checker view, in the transverse loading of the wrist, you can see the weight over here. You can see that the radius and the wrist now can have something to drop on and to rotate on, like it should be in the normal anatomy. So the literature on the technique, it has been described several times. This has been published in German and in the English language, so everybody can actually read that up. The indication originally for this procedure from Tim and me was a revision of failed resection arthroplasties to restore stability in the painful forearm instability following ulnar resections. Contraindications are insufficient bone quality to allow for osseous integration, insufficient soft tissues to stabilize the whole system with the original soft tissues, especially after several previous operations or in rheumatoid patients, or longitudinal forearm instability following Essex Leprosy injuries, because in these patients, that small distal flap will not restore the complete forearm stability. This is an example. It was my first patient in Germany. At that time, he was 48 years, and he was a laborer, heavy laborer. He had this procedure done in 1996, and these are his X-rays 23 years following ulnar head replacement. These are his CT scans in forearm rotation. This is in the neutral position, in pronation and in supination, showing absolute stability of the forearm joint. And actually the CT scan demonstrates osseous integration of the stem within the shaft of the ulna. These are some clinical pictures with forearm rotation and grip strength. He was right-handed and the affected side was the right side. So after 23 years, he had a dash of 6 and he had on the dominant side more grip strength than on the non-dominant side. So he had more grip strength on the side. He had the replacement than on the non-replacement side. This is another example, patient with 4 operations after a tumor resection, giant cell tumor resection, including tendon stabilization. And in this patient, the length discrepancy was so big that we needed a custom-made extra long neck prosthesis with a neck of 48 millimeters. And you can see here the X-ray after 103 months with a prone supination of 65 degrees and a grip strength of 88% and a dash of 2 in this patient. Well, what about the failed painful instability following Carpentry-Sauvé procedures? Diego Fernandez came up with the idea that we don't try to stabilize, to restore stability with a soft tissue flap, but what we do is, or what we can do is that we create a bony support for the ulnar head prosthesis, and we don't use that flat ulnar head, but a spheric ulnar head, and I'll show you in a second. He actually described that in 2006, that procedure with some limited results on clinical patients. And this is what it looks like. You ream a ball and socket system under the bone block of the Carpentry procedure, and then we use a spheric ulnar head and we restore the stability, not by means of a soft tissue procedure, but in a bony way, like a ball and socket joint. If we have a specific situation, like in this case over here, so we have not only a painful instability of the forearm, but we have ulnar impaction syndrome because the fusion of the ulnar head was performed in ulnar plus situation, then we only address one problem if we restore the stability. So in these patients, I actually try to unpick the fusion block and restore the stability with a custom-made prosthesis with an extra long neck, as in this patient over here. And you can see the X-rays 98 months following the procedure in this patient. So when we finished the final design of the prosthesis after several anatomical studies and cadaver studies, we asked ourselves 3 questions. And I think whenever you implement something new, a new method or a new system, you have to ask these 3 questions. The first question is, can we do it? Is it possible? So to answer this question, we only implanted 3 prostheses in 95 in Australia. And then we waited for 1 year and we followed these patients up. And we did see that it is possible and it can be successful. And we published the results of these first 3 patients. The next question that has to be answered is that system reliable and can it be reproduced by other surgeons as well? So to answer that question, we implemented an international multi-center study in 1997, including our center in Germany, and Diego Fernandez Center in Switzerland, Bill Bauer's Center in the States, and Tim Herbert's in Sydney. And we did a prospective study, treating another 20 patients with that method. And then we waited for another 3 years, and we followed these 20 patients up. And in the final follow-up after 3 years, we could show that it is a reliable procedure and it is a reproducible procedure. Still then, this is not the end of the line, especially if you create an endoprosthetic system. The next question that has to be asked and has to be answered is that system lasting? So in the last step, we try to follow up all the patients, all these 23 patients that we treated originally in the first 2 steps. And with a mean of 11 years of follow-up, we could show that the results that have been shown in the midterm and short term have been lasting over time as well. And all these obviously have been published. So in the next step, a fellow of mine tried to review the patients of mine in 2012, all the patients that I operated between 96 and 2012. And these were originally 91 patients, and he was able to review 62 of them with a mean follow-up of 7 years. And radiologically, he could see no signs of loosening of the prosthesis. We did see in 39 of these patients a resorption under the neck of the prosthesis of the bone of the ulnar, but this had no influence on the clinical results. We did see some remodeling, what we call remodeling of the sigmoid notch in 8 of 62 patients. These are osteophytes on the dorsal and palmar rim of the sigmoid notch, but that did not have any influence on the clinical results neither. What we did see, and that is something that really sometimes happens, we did see a deep migration of the radius onto or into the ulnar head. We did see that in 5 of 62 patients, and it was clinically only relevant for the supination, with an average of 41 degrees of supination in these 5 patients compared to 60 degrees in the other patients. One patient showed heterotopic ossifications around the ulnar head prosthesis. So what we see, this is an example for what we see on the radiographs, one of our first patients as well, in this hemi or resection arthroplasty. And these are the X-rays 153 months following ulnar head replacement. You see that resorption under the neck of the prosthesis, and you see these osteophytes that actually go around the ceramic head of the prosthesis. But as I say, this stabilizes the system, but it does not have any influence on the clinical result. So preoperatively, all of these patients had an unstable situation. In the long term, none of them had an instability clinically after a restoration of the forearm system. We had preoperatively a pronation of 65, a supination of 56, postoperatively of 67 and 60 degrees. The grip strength decreased from 59 to 81% of the unaffected side, and the pain measured on the visual analog scale was reduced from 6.7 to 2.5 after 7 years of follow-up. The DASH decreased from 56 to 39 post-operatively, but we had a DASH in the patients where we had a wrist fusion of 51. So in a lot of patients, we did not only have ulnar head replacement, but problems on the radial side of the wrist as well. So in the patients where we had an additional wrist fusion, we had post-operatively a DASH of 51, and without a wrist fusion, a DASH of 34. We had altogether 16 revision procedures with 2 explantations of the prosthesis in our 91 patients we treated in these 12 years. The 2 explantations of the prosthesis, one was due to an infection, and that only had to be solved with explantation of the prosthesis. The second one had a dislocation of the radius against the ulnar head replacement and secondary loosening of the prosthesis. That patient had a radial malunion, and we treated that with a secondary radial correction osteotomy. And this is the case. It was a 28-year-old female. She had distal radial fractures, developed painful arthritis of the distal radio-ulnar joint that was treated with that hemiresection arthroplasty of the distal ulna. We tried to solve that with ulnar head replacement, and you can see the radius still being palmar to the ulnar head replacement, and that was due to a palmar malunion of the distal radius. So our next step was we left the prosthesis. We performed the radial correction osteotomy, so we actually got the radius back to the place where it belongs, parallel to the distal ulna, and then we changed that small stem of the ulnar head prosthesis to a larger stem. And these are the trays following the plate removal, and you can see the stable situation of the distal radio-ulnar joint after we have restored the normal alignment of the forearm bones against each other. These are the clinical results with an almost full forearm rotation and a good grip strength compared to the opposite side. So altogether, if we look at all studies that have been performed on this prosthesis, we have a 15-year survival rate of 90.3% in the Kaplan-Meier survival scale. After we have seen that this method works very well to restore stability in the painful instability patients following resection arthroplasties, obviously we increased the indications, and we increased it especially in the young and demanding patients to primary reconstruction in the destroyed distal radio-ulnar joint. Because what we did see is that most of our patients with resection arthroplasties that failed and developed painful instability were young and demanding patients. So this is an example. The patient following a malunion of the intra-articular distal radial fractures developed radiocarpal painful arthritis as well as distal radio-ulnar joint arthritis. First, we performed a radioscapholunate fusion, and then we primary restore the distal radio-ulnar joint with an ulnar head replacement. And actually 6.5 years after that ulnar head replacement, that patient came back to us because he had still pain on the radial side due to a non-union of the radioscaphoid fusion. And we revised that, resected the distal pole of the scaphoid, and performed a revision of the radioscaphoid fusion. And we actually did see in 14 years following that operation with a very, very good clinical result and a very sufficient dash. Actually, this is only one example I want to show you that, you know, if you have success with the procedure, you sometimes increase the indications more and more. This was a horrible fracture of a 41-year-old male, and he was treated in another hospital, primary in this way, and the ulnar head obviously was vaporized and had to be removed. He developed that situation with an ulnar head, a lost ulnar head, and you can see the CT scan in this patient after that. It was already a radial correction osteotomy after removing of the first osteosynthesis. And you can see on the CT scan the loss of a complete sigmoid notch and ulnar-sided distal radius, as well as of the ulnar head. and Karl Prommersberger and me decided that we give it a try together. So we used an iliac crest bone to reconstruct something like a sigmoid notch of the radius and performed ulnar head replacement in this patient. Unfortunately, we did see him one last time about 67 months after that reconstruction, because we had to remove these screws as they were rubbing on the ceramic head. So we removed the whole hardware, and at that time he had a dash of 16, and we try ever since to bring him back for a review, but he comes from about 400 kilometers away, and he says, I'm not going all that way, only to see you. I'm happy with what I'm having. So in summary, I think that reconstruction of the original distal radial ulnar joint using a biocompatible spacer, an ulnar head prosthesis, is the only reliable procedure to restore stability in failed resection arthroplasties of the distal radial ulnar joint. The Herbert ulnar head prosthesis has been investigated in these prospective studies for over 25 years. Yes, I think it has stood the test of time. It is indicated in all patients with painful instability following a Carpentier procedure or resection arthroplasty, if we have sufficient soft tissues for stabilization, and it is indicated as a primary treatment for the painfully destroyed distal radial ulnar joint in the young and active patients. But, and I'm coming to the end of my presentation and my thoughts about ulnar head replacement, but despite all the good results we see with the ulnar head replacement, obviously we will see problems, as we do see them in all joint replacement surgeries, especially if we increase the indication and the use of the prosthesis. So that might be recurrent instability, like in this patient. As I told you before, migration of the radius onto or into the ulnar head, or periprosthetic fractures, as in this patient. But with this procedure, we do have revision options. And the revision option is the complete replacement of the distal radial joint. And the indication for me is revision of failed replacements, and especially the patients where we have contraindications for simple ulnar head replacement. And we do it to avoid a one-bone forearm. And that is the Schecker prosthesis, and that is complete and replacement of the distal radial ulnar joint. Just one intraoperative example over here with a radiological example from our clinic. We do have promising midterm experience in 27 patients, but all of them had a very special indication, and we performed the Schecker prosthesis to avoid one bone forearm as a revision of revision procedures. This is one patient over here where we used the Schecker prosthesis following an acephaloplasty injury, following 12 previous operations, to restore some kind of forearm rotation, or in this patient, 35 years old female, Madelung's deformity with 14 previous operations. So in the end, we decided to remove the hardware to perform another correction osteotomy of the radius, and then restore stability of the forearm with the Schecker prosthesis. So let me present you my algorithm as I use it in our clinic and in our hand center nowadays. If we have patients with painful post-traumatic destruction of the distal radial joint, we perform a step-by-step algorithm, as I do not want to burn bridges right with my first procedure. So in the old and low demanding patients, we still perform either the hemiresection arthroplasty or the Carpentier procedure. In the young and demanding patient, we restore forearm rotation and reduce the pain by primary ulnar head replacement. If we really have the situation of painful instability following resection arthroplasties, my treatment is secondary ulnar head replacement to restore forearm instability in all patients where we don't have any contraindications. If we have contraindications for simple ulnar head replacement, or we have to revise recurrent instability despite of restoration of the forearm stability, or in essexual situations, I perform the Shaker prosthesis. If the Shaker prosthesis loosens out or has major problems, then the only salvage is one bone forearm, or, and I don't want to go in depth to that, a constrained replacement of the proximal and distal radioulnar joint. But this is something for the future. I'm going to tell you if I have more experience with that. Thank you for your attention. I hope I could actually show you the way to that system and where I do see the indications nowadays.